Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Oxnard Health System, and Humana to bring Oxnard's Hello Health weekly education and information series to television. Tonight's topic, advances in the imaging and diagnosis of prostate cancer, as well as innovations in personalized cancer therapy. Our guest is urologist Stephen Bardot. First, some background. Dr. Stephen Bardot is the chairman of the Department of Urology at Oxnard. He attended medical school and did his residency work at Kansas University. His fellowship in urological oncology took place at the Cleveland Clinic. And it is our pleasure to welcome back to Hello Health, Dr. Stephen Bardot. Good to have you with us on the program.
Yes, thank you, Tom. It's great to be back.
Yeah.
Thank you.
So let's start with how common prostate cancer is. Certainly for men, it's the one cancer that most men talk about or are exposed to.
Yes, it affects more families than any other cancer from a male perspective. In the U.S. last year, over 260,000 men were affected with prostate cancer. Or, I'm sorry, 164,000 men were affected with prostate cancer, which is enough to fill the Superdome twice plus, and over 20,000 men died from the disease. So it's an incredibly common problem for U.S. males. At this time, almost 3 million men in the United States are actually living with prostate cancer, so it affects a lot of men and their families.
What about in Louisiana?
It's a big problem here also. It probably wouldn't surprise you that Louisiana is the second highest cancer rate, prostate cancer rate in the United States, and has the seventh highest rate of death from prostate cancer. So it's a particular problem in Louisiana and other southern states around here. Has
it been studied why the numbers are higher in Louisiana and why the fatality rate would be higher?
We don't know for sure. We think part of it is a higher proportion of African Americans to Caucasians, and then probably also has something to do with fewer men getting prostate screening and catching it early when it's curable versus catching it later in the disease course when it's more likely to cause problems.
You mentioned a couple of the risk factors. Kind of go through them all for us, if you would.
Sure.
Risks for prostate cancer.
One of the big risks is age. Although we do see prostate cancer in men in their fourth and fifth decade, it definitely gets more common as we get older. About 60% of men with prostate cancer are diagnosed after the age of 65, and so as we age, the risk of prostate cancer goes up. As already mentioned, African Americans have a higher rate of prostate cancer than non-African Americans, about 60% higher. Also, some other risk factors that we're aware of, family history. About 10% of the cases in prostate cancer are from men who've got it in their families. And so for men whose father or brother has prostate cancer, we estimate that they probably have a 2 to 3 times higher risk of developing prostate cancer than men without that family history. We also have learned in the past that chemical exposure, for instance, in the Vietnam War, men who were exposed to Agent Orange have a higher risk of prostate cancer. And then we think that in the U.S., one of the reasons the rate is so much higher here is our diet. The Western diet, which is higher in red meat and saturated fats, seems to predispose to prostate cancer as well as heart disease and some other maladies that are more common here than in other countries.
As you have educated and others have done so on this program, the prostate is always growing, right?
Yes.
But that doesn't necessarily, and that sometimes can be an indicator of prostate cancer, but just because you have an enlarged prostate does not necessarily mean you have prostate cancer, correct?
Exactly right. Once we hit puberty, our prostate starts growing and never stops. And most of the time, that is just benign growth that may affect urination in some ways. But prostate just as the enlarged prostate gets more common as we get older, prostate cancer similarly gets more common as we get older. And so that's the key of sort of working with your family doctor to make sure we're getting our PSA checked and the prostate checked to make sure nothing unusual is going on.
How's prostate cancer usually diagnosed?
Since the 1980s, prostate cancer is always diagnosed with biopsy. So a PSA test alone or an X-ray alone doesn't make the diagnosis. We actually need tissue to prove it. And the way we've done that since the mid-1980s is to use a prostate ultrasound. It's a small probe that allows us to look inside the prostate, much like a mammogram allows us to examine breast tissue. And that is how we typically will examine the prostate as well as guide our biopsies to suspicious areas.
So are you going in and just observing, or are you going in and taking?
Can be used either way. It can be used to visualize it as well as guide the biopsies.
Is that the definitive testing tool being used today?
More recently, the technology has changed. We've learned over the years that although ultrasound is helpful, it's not perfect. Half the time it can't see the prostate cancers that are present, and so it makes it more difficult. If you can't see half the things that you're trying to see, that it's going to cause challenges. And so when we rely on ultrasound alone, oftentimes we have to do more frequent or repeat prostate biopsies because we didn't get it the first time. Also, it tends to not discriminate the high risk or aggressive prostate cancers, which are the ones we really want to find, versus a slower growing or more indolent one, which we can safely watch. And so more recently, MRI, particularly the 3T MRIs, do a much better job of actually looking at the prostate, as well as helping us look at the physiology of the prostate, telling what's going on there by blood flow and other measures.
So let's talk more about these latest innovations and what you're seeing and how helpful it is to you and other urologists.
It's really been a game changer for us. It allows us to, and it sort of requires both the technology and the people who can use it. And so we have a couple of radiologists. Dr. Rudman is one of them. Dr. Tupler is one of our radiologists who specialize in interpreting MRIs of the prostate. And then with the 3T MRI and the new software, we can actually not only see into the prostate, but look at what's going on physiologically. Is there areas with more blood flow, which can help point us to where a more aggressive prostate cancer might be?
And how does magnetic resonance imaging, or MRIs, help in the diagnostic process?
It really gives us a different way of looking at it. Ultrasound uses how much sound waves reflect back. MRI, by looking at it within a magnetic field, actually tells us physiologically how that tissue is acting, or if it's not acting like normal tissue in the prostate, and then helps us localize where it's at and where we need to pay attention to as far as the disease process.
And MRI fusion technology, and how is that helping?
That's really been a game changer also, because now when we see that abnormal lesion on the MRI, we have a software program that takes the MRI image and combines it with the ultrasound. So when we're looking on the ultrasound, we're actually looking at a 3D representation of the MRI. And as you can see on the monitor, the prostate's represented as sort of the red area, but the tumor is, or the cancer or suspicious area, is the green area. So we can not only localize it, but it tells us when we've actually biopsied the suspicious area. And so that's really helped a lot to know that we've hit the target of interest and we're going to get the answer we need.
Is this available all over? Is this just something Oxnard has gotten into?
It's getting more common. MRIs are everywhere. If you've ever had a knee injury, you've had an MRI before, and so it's a tool that's used all the time for back and joint pain. The 3T MRIs are really what are required to do a good job on soft tissue imaging. And so the 3T MRIs with what's called multi-parametric input, where they can actually look at the physiology, are much less common and require a special machine as well as special software to be able to interpret those images.
You think we're catching more cases of it?
We're catching more aggressive cases. Most of the data is now showing that MRI helps us in two ways. One, it's doing a better job of catching the aggressive cancers, which are the ones we want to know about and our patients want to know about. And it also tends not to pick up the real small, slow-growing one, which would never be an impact on the patient's life. So it's really helping us focus our diagnosis and treatments on the ones who really need it, and causing less angst and anxiety in the ones who we really don't need that, since it's not going to help them.
Talk to me about the conversations you have with men, and as you pointed out at the very beginning of the program, many men will have this conversation and hear this news, is we have found prostate cancer. You've just talked about the different levels and different kinds. How do patients react to this news, and what role does the physician play in comforting them in knowing that there are options, and it seems like more and more there are better options for patients with prostate cancer?
Yeah, I think the key is medicine is changing. If we look historically, we based all of our conversations on the last 100 patients we had seen and what it looked like on radiographs or x-ray, what it looked like under the microscope. But we've learned that Mr. Smith's tumor, although it may look similar under the microscope, may behave very differently than Mr. Jones' tumor. And so we have a lot of clinical information and risk stratification tools that we have now that really help families know, this is what I'm dealing with. These are the risks of this tumor impacting me over the next 10 years. And if it's 1%, that's a different scenario than if it's 90%. And so they can sort of weigh what they need to do. Can we safely watch it? Or do we need to be more aggressive? And that's where both the imaging modalities as well as some of the new genomic tools that we're using can help steer patients and give them better information to make a better decision for their health care.
And the tumors themselves may be the same, but Mr. Bardot is not Mr. Bagwell, and how Mr. Bagwell reacts and how Mr. Bardot reacts may be two completely different ways, right?
Absolutely. And that's why I think in the best case scenario, it's usually not just the patient in the room, but their spouse and maybe other family members, so that everybody is at the table. There's 6 ears listening rather than 2, and really can really phrase it of, well, this is what it's likely to be your impact, and these are our options for how we can deal with this going forward.
Dovetails nicely. Our guest is Dr. Stephen Bardot, urologist, and tonight we're talking about prostate cancer and the different ways and new innovative ways it's being diagnosed, obviously treated as well, and personalized cancer care. So this dovetails nicely into where we're going to move now. What do we see new in this area of personalized cancer care?
It's been a huge change in the last several years. We've been getting more and more tools that actually look at what's called the genomics of a patient's tumor. And so typically that involves taking the tissue we got from the biopsy and actually analyzing the genes that are in that tissue to tell us how it's going to act going forward. And there's actually 3 different genomic tools that are used in prostate cancer now that can help us with that, including...
Tell us about those and how they differ.
So there's 3 different tests that have been researched well enough that we know that they work, we know that they add value, and there's enough information there that most of the insurers are now covering that. And so it used to be one of those things that only a few patients could afford to have that done, but now that they're covered, they're much more attainable for most of the patients. But there's 3 basic tests. There's the Oncotype DX, which looks at a number of different genes on how cancers behave. There's a test called Decipher that looks at some RNA tumor markers. And then one we've done a lot of work with and research with at Ochsner called Prolaris, which looks at 46 genes that are involved in the cell cycle. So cancer cells typically grow much faster than normal cells and sort of grow without the controls that normal cells have to keep them sort of in check. And so the Prolaris test actually looks at what is the engine, the genetic engine in these cells. Does it have the engine to grow really rapidly over the next couple years and cause problems? Or is it more indolent and isn't going to cause problems down the road?
When do you know which test to use, and is there times you'd use a combination of these tests?
Generally, you pick one. We've worked with all the tests that are out there. One of the challenges we have with these tests is when we look at a lot of their initial testing, it might be done in the Netherlands, it might be done in some other part of the United States. And it may not be checked on both African Americans and Caucasians. And so we did a lot of work with Prolaris here because almost 40% of our patients are African American, and found that this tool worked just as well for African Americans as it does for Caucasians.
What are the challenges we face for prostate cancer in treatment decision making?
Yeah, there's two real challenges that we deal with. One, it's estimated that anywhere from 30 to 50% of men who are diagnosed with prostate cancer, their tumors are so slow and so slow growing that they may never need treatment, and we can safely watch those tumors over the years using the PSA test, using the MRI, and if and when the tumor looks like it's changing, we can do therapy there. So we avoid side effects from treatment until we absolutely know they're needed.
I'm going to die of, in many of those cases, I'm going to die of something else.
Yes,
right?
yes.
Yeah.
We're all going to die of something.
That's right.
The key is knowing which ones prostate cancer is not going to be a factor for. Mm-hmm. And at the same time with prostate cancer, we also have some very aggressive tumors that we've learned that oftentimes just one treatment alone may not win the battle, and we may need to hit this thing in a couple different ways to knock it out. And so that's really our challenge, and that's where the genomics helps, is it gives us additional information to help answer the question, can we safely watch Dad's tumor, or is this something we may need to throw everything in the kitchen sink at?
I'm just thinking from a patient's perspective. In the past, you would have said, well, I got to tell you, this percentage of my patients we would watch, and this is what happened. This percentage we were more aggressive and went in with surgery or radiation or whatever. Whereas now you've got more science behind the recommendations you're making.
Exactly. And, a lot of patients, when I'm having this conversation, I tell them, particularly the ones with the more aggressive tumors, we're at war with this tumor, and the more information we can have about the enemy, the better decisions we can make as far as what we need to do to win this battle or not. And that's where the genomics really have sort of, at least in our study here, gave us almost twice as much meaningful information for the patient and their family and their cancer doctor to make a good decision as to what do we need to do, what do we not need to do to get the most impact in their life.
We'll return back to the primary focus in a moment, but I remember one of the programs we did many years ago, in fact, I think we got more calls that night than any other program we've done, was on the use of robotics in prostate cancer surgery. Right. Can you just give us a quick update? Is that still the norm, and are we seeing advances in that area as well?
Yes, we've been using robotics at Ochsner Clinic for 15 years now. And like in everything else, the technology keeps improving and changing. We're actually on our third generation of robots now that do a much better job with visualization, dexterity. We actually now have tools there where we can actually look at the blood flow to the tissue to help gauge margins to make sure we're taking just the tumor and leaving normal tissue behind. And so robotics from a surgical perspective has been really impactful in helping us do a better cancer surgery, but minimizing the side effects of surgery when it comes to urinary control and sexual health, and making sure we try to maximize the impact for the cancer, but minimize sort of the negative quality of life issues that can come from prostate cancer treatment.
We touched on this, but what are you finding with this new Prolaris testing, its impact on family decision making?
We're still learning, and so we're still at sort of the beginning of the genomics journey. But what we've learned from using the Prolaris is that it's giving both the doctors treating the patient as well as the patient's family much better information as far as what they need to make the right decision. Whether this is a tumor that under the microscope looked like it was fairly slow growing and we could safely watch, under the genomics we may find that it was actually a wolf in sheep's clothing, and it's actually a more aggressive tumor than we thought previously. And so we can change our plan as far as what's going to be the best treatment for that patient.
And what are you finding? What have you learned at Ochsner about the impact of the Prolaris test on prostate cancer?
It was I was actually surprised how often it changed what we knew. I thought it was going to be sort of a 10% game changer, and we actually found that over 50% of the time it gave us information we didn't know before. Most of the time it was telling us a tumor that looked like it was going to be sort of a sissy, and it wasn't going to be anything we had to worry about. When we looked at the genetic engine, that's like, this thing can really cause problems down the road. We need to rethink about it. And then in some patients, a little bit less than 10%, we actually found that what looked worrisome under the microscope genetically didn't look nearly as bad. But it really helps us on those patients who all the other information said we were safe to just watch it, that it says, oh, maybe not. Maybe we need to think about doing something, or else watch them more frequently for signs that it is acting differently than we would or we anticipated.
Have you found it to be helpful to you, to be more convincing to patients? Because ultimately, people hear the word cancer. Most people by nature would want to be aggressive, right?
Right.
Get it out, don't want to have anything to do with it, don't want to run the risk, versus you in the past, saying one of two things, right? Hey, I know how you feel. That's the way most of my patients feel, but let me tell you why we want to just watch this and wait, or go the other route.
Yeah, that's actually, I think, one of the biggest challenges I have as a clinician, because obviously I don't know if there's 6 letters in the English language that are more frightening than cancer. And so when people hear that applied to themselves or to their loved one, they want it out, or they want to use radiation, and that's their first knee-jerk reaction. And so oftentimes, particularly for those ones with the very small, slow-growing tumor, getting them to the point where they can feel comfortable that we're going to do a good job working together to keep an eye on things. And that's also a key point, is they know this, even non-treatment, is a journey we've got to go down together. And so it's not, I'll see you in 5 years. It's every 6 months we're checking a blood test. Probably in another year we'll repeat an MRI. And then we revisit that conversation down the road, because we found that in time, even if that first conversation is successful and they say, oh, that's great, when that next PSA test comes back, the whole anxiety issue blooms again, and so we have to sort of go through the conversation. And some folks, just because of how they can deal with it, even though the cancer data tells us we can safely watch it, we may wind up treating it just for their peace of mind so they can get on the other side of this and sort of live their life again.
We talked about robotic surgery, but in the cases where there is going to be treatment, it's not just going to be surveillance, is this new testing information that we're talking about tonight helpful in deciding which treatment option to use?
Yeah, we actually learned that it was helpful. The 2 main curative therapies that we have in prostate cancer for localized disease are either prostate cancer surgery or radiation therapy. And we found that the genomics actually helped predict which patients were going to do well with either treatment, and also similarly which ones probably weren't and might need to think of something else or do something in addition to one therapy or the other.
Encouraging signs.
Yes.
Glad to know there's good news on the horizon, and look forward to more when you come back to be with us. Dr. Stephen Bardot, thank you so much.
Thank you very much, Tom. That was
always
great.
Interesting, terrific guest. I want to thank Dr. Bardot for the education and information he's provided tonight, and for his work in the Ochsner Health System. To make an appointment with any Ochsner physician, including tonight's guest, you can call a special number set up just for viewers of this program. Our phone number is 504-842-5669. That's 842-5669. Or you can send us an email. Here's our address, hellohealth@ochsner.org. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com. Ochsner's website has many of the programs there, too. We hope you'll take a look. Our thanks again to tonight's guest, Dr. Stephen Bardot. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of our program, Hello Health, and our station, WLAE. Good night.